Hello, students. Welcome to chapter 18, Gastrointestinal and Accessory Organ Problems. This is a long chapter, however, it's going to help you in the development of your final project. Most of the diseases that I already assigned to different groups are included here. Do not misunderstand that you can only have this source, this book, to complete your final project, but at least it's going to give you a good umbrella of what the topics are needed to cover that particular project. Okay, so in this chapter we are going to analyze the diseases of the gastrointestinal tract and its accessory organs interrupt the body normal cycle of digestion and absorption and metabolism. Food allergies result from an inappropriate immune response to certain proteins found in food, and underlying genetic diseases may cause metabolic defects that block the body's ability to handle a specific food. So that's what we are going to cover. Let's start with the upper GI tract, and we are talking about the mouth. So in terms of dental problems, we have dental caries or cavities that result from the combined effect and presence of bacteria and fermentable carbohydrates. Also, fluoride toothpaste are effective for preventing dental caries at fluoride concentration of 1000 ppm. Right? However, untreated tooth decay still plagues some 20% of children and 32% of adults in the United States. So that's why it's very important to have proper dental hygiene. Okay. Elderly individuals who are missing teeth or have ill-fitting dentures are prone to compromise nutrition status due to, in part, to avoiding certain types of food that are painful or difficult to eat. That's where malnutrition come into place, right? Specifically, people without healthy teeth frequently avoid foods that are such as whole fruit, vegetable, meats, and other high-fiber foods, and opt for energy-dense, easy-to-chew foods instead. However, this is the problem, right? Because with energy-dense food, many of them, they are rich in carbohydrates. So that's where the fermentation, okay, occurs in the mouth and the cavities appear. So about 43% of adults over age 50 in the United States have tooth loss to the point of non-functional dentition, and especially consider those with lower socioeconomic standing. Sometimes a mechanical soft diet is helpful for individuals who are lacking teeth. For such a diet, all foods are soft cooked and meats are ground and mixed with sauces or gravies, so that's less chewing is necessary. Okay. Basically here what we are reinforcing is assessment. You have to look into the dental cavity in order to assess the issues and identify the problems, right? To first address them, and then the patient is going to be able to have proper nutrition. Surgical procedures are multiple approaches, but let's focus on oral tissue inflammation. Malnutrition, specifically in severe states, causes the deterioration of the oral tissues, which may result in local infection or injury that brings pain and difficulty with eating. So the following conditions of the oral cavity can contribute to malnutrition. We have gingivitis. Okay. Let me highlight this. Inflammations of the gums. Then we have a segment here called cultural considerations that I invite you to read. There are some cultures that they are not reinforcing this oral hygiene as we reinforce here in the US. And you have also, we spoke first about the gingivitis. Now, oral mouth ulcers may develop from infectious sources such as the herpes simplex virus. Okay, this is where most of the concepts in different areas combine. Okay, herpes simplex virus, which causes mouth sores of the inside mucous lining of the cheeks and lips, or on the external portion of the lips. Then you have Candida albicans, which causes similar sores on the oral mucosa and results in the condition called candidiasis or thrush. And then we have hemolytic streptococcus that causes the mucosal ulcers that we commonly call anchor sores, right? Clients with an underlying illness such as cancer or HIV, both of which diminish the body immune system, often have mouth ulcers. So that's another factor that we need to measure when we do assessment. Where is this patient coming from? What type of treatment is the patient dealing with right now? Clients with an underlying illness such as cancer or HIV, both which diminish the immune system, often have mouth ulcers. Now, chemotherapy and radiation treatment to the mouth destroy the fast replicating cells in the oral tissue and can cause the painful mouth sores. These patients are in extreme pain, so the nutrition have to change, as we spoke in a previous chapter, right? In these situations, eating may be painful. Clients can usually tolerate progressing from nutrient-dense liquids that are high in protein and calories to soft foods. Room temperature, soft or liquid foods are usually better accepted. Also consider the use of topical local anesthetic before meals, and it's going to help to relieve the irritation caused by eating. Now let's switch gears to salivary glands. Okay, so problems may arise from infections such as the mumps virus that attack the parotid gland. Other problems arise from mucocysts and obstructed salivary ducts, typically on the lower lip or the insides of the cheeks. Both excess salivation and inadequate salivation can interfere with eating and salivary gland function. So numerous disorders that affect the nervous system, local mouth infection, injuries, and drug reactions cause excessive salivation. Conversely, a dry mouth from a lack of salivation may be temporary and caused by fear, infection, or a drug reaction. And here comes a term that I want you to remember that's good to know. Xerostomia, chronic dry mouth, is often associated with rheumatoid arthritis or radiation therapy, or it may occur as a side effect from many chronically used medications. Okay, xerostomia causes swallowing and speaking difficulties, taste interference, and tooth decay. So here we have some pictures that are very graphic in terms of tissue inflammation of the mouth. You see A is gingivitis, then B is stomatitis, then C, glossitis. You can see the tongue, okay, and then chelosis on picture D. Now, the addition of more liquid food items to regular meals, such as beverage, soup, stews, juicy fruits, and gravies or sauces, may facilitate the eating process. Spraying an artificial saliva solution also will help. And think about those patients with Sjogren's syndrome, right? Sjogren's syndrome is an autoimmune condition that causes a lack of tears, lack of saliva. This patient will benefit from spraying an artificial saliva solution or the addition of more liquid food. Now let's talk about swallowing disorders. Okay, this is a very important topic. okay, because it's going to help you understand, and also in the nursing interventions for patients with Alzheimer and Parkinson disease. So swallowing disorders, it may be only temporary. A piece of food lodged in the back of the throat could be that the reason. An abdominal thrust may be appropriate first aid. However, dysphagia is a chronic problem in some patients, and it is particularly common among those with neurologic disorders such as Alzheimer's and Parkinson's, as I mentioned before, and stroke complications. Other common causes of dysphagia are head and neck cancer, tooth loss, xerostomia, we know already, xerostomia is dry mouth, neurodegenerative and neuromuscular disorders, post-intubation trauma, and muscular weakness of the larynx, right? So, to treat dysphagia effectively, a speech-language pathologist identifies if the problem is a mechanical obstruction, that it could be, for example, a food lodged in the back of the throat, or a neuromuscular disorder, and diagnoses the situation accordingly in terms of dysphagia. So now, here we have the location of the salivary glands, a concept that we just covered. And let's move. Okay, my computer is kind of slow today. Symptoms of dysphagia include an unexplained drop in food intake or repeated episodes of aspiration-related pneumonia. Remember, I always tell you that we need to know our map. Anatomy is the key here, right? A few paragraphs before, we were talking about the larynx, okay? So we have to remember that we have two tubes in our in the upper part of our body. So in front, in the anterior part of the chest, we have the trachea, and behind we have the esophagus. And before the esophagus is coming the larynx and the pharynx, okay? So symptoms of dysphagia include an unexplained drop in food intake or repeated episodes of aspiration-related pneumonia. So if the patient is having issues swallowing and the food does not go from the larynx to the esophagus, it's gonna enter the trachea, which is in the anterior canal that I just mentioned, right? The presence of dysphagia significantly increases a patient's length of stay in the hospital. Now, also increases the risk for malnutrition, right? And personnel, all of us, you know, our assistive personnel, our CNAs, nurses, PAs, everybody should watch for warning signs of dysphagia. Reluctance to eat certain foods, consistency, or any food at all, very slow chewing or eating, fatigue from eating, frequent throat clearing, complaints of food sticking in the throat, pockets of food held in the cheeks, painful swallowing, regurgitation, and coffee or choking during attempts to eat. Those are symptoms of dysphagia. So think about your elderly patients. They never complain. They never express what is going on. So you have to really assess, pay attention the ways they are swallowing, because sooner or later, most of them, I would say more than 90%, are going to have dysphagia issues, either because it's coming from neurodegenerative condition or any other condition, okay? So please do proper assessment on your elderly patients. Clients with dysphagia do not always exhibit other signs such as coughing when food enters the airway, silent aspiration, or aspiration that occurs without a cause. A cough is a common cause of complications. So there you go. ECLEX alert, safety, because sometimes it's asymptomatic. The speech language pathologist may recommend swallowing techniques that help prevent aspiration, such as sitting in an upright position. That's crucial, sitting in an upright position when eating, chin down, positioning when consuming liquids, and clearing the pharyngeal cavity with dry swallows. Thin fluids are generally the most problematic to swallow properly. Now, the standard practice is to adapt the diet to individual needs in stages of thickened liquids and puree foods. Puree foods are generally the consistency of mashed potatoes or pudding. Care providers may use a food processor to puree regular table food to achieve the desired consistency. So that's good to know. Also, how can we provide, can we assist in the nutritional part to our patients. Now let's talk about the esophagus. We know that the esophagus, so we are going in order, right? We start with the mouth, we went to the throat, the salivary glands. Now we are talking about the esophagus. This is a muscular tube that extends from the throat to the stomach, and circular muscles or sphincters bind both ends of the esophagus and act as valves to control the passage of foods. So various disorders along the tube may disrupt normal swallowing, like muscle spasm, stricture or narrowing of the tube caused by scar tissue from a previous injury, the ingestion of caustic chemicals, a tumor, or maybe esophagitis. Okay, those are the common causes. The diet during such problems ranges from liquid to soft in texture. Now, lower esophageal sphincter. Lower esophageal sphincter. This is a functional defects that can occur from changes in the smooth muscle itself or from the nerve, muscle, and hormone controls of peristalsis. So spasms occur when the lower esophageal sphincter, which we are going to call from now on LES, maintains an excessively high muscle tone when even while resting, thereby failing to open normally when the person is swallowing. So there is a high muscle tone, difficult to open, failing to open normally when the person swallows. This condition is medically termed Acalasia, commonly referred to cardiospasm because of its proximity to the heart. There you go. Okay, so many people, when they feel Acalasia, excuse me, sometimes they believe they are having a condition in the heart. Okay, so symptoms include difficulty swallowing and frequent vomiting. Of course, because the LES is having a excessively high muscle tone, difficult to open normally. Okay, so that's why the people is vomiting. That's good to know. Difficulty swallowing. Okay, so the intake is not complete. The food doesn't get to the stomach because of this high muscle tone of the LES, and people start vomiting. So here, for further focus, the International Dysphagia Diet Standardization Initiative has recently set for a descriptive framework for testing and clearly categorizing each of the seven food and liquid consistencies within a dysphagia diet. So here you have the 7 food and liquid consistency with a dysphagia diet. And you see at the bottom of the pyramid here, I think, number 1 is a slightly thick diet. Number 2 is mildly thick. 3 is moderately thick, or it could be liquidized. Okay, number 3 is share in both types of pyramids. Then you have extremely thick, which is called also puree in the other pyramid. Now we are changing to more consistent food, right? We are having number 5, mince and moist. Number 6, soft and bite size. And number 7 is regular diet, regular food, okay? The official launch date in the United States for using this IDDS framework, and IDDS stands for the International Dysphagia Diet Standardization Initiative. So this was implemented in 2019. Recent studies have questioned the use of modified texture foods because patients are not accepting or complying with the diet, nor has it consistently or slightly improved the overall health outcome of patients. So here the book is telling you that even though this new pattern has been created, recent studies have questioned the use of these modified texture foods. There is a link here. See the iddsi.org/framework for details on this framework. And that would be very helpful if you decide to work, for example, in a neuro unit, okay, or a cancer care unit, or elderly unit. You need to be familiarized, okay? So let's continue with that concept. So symptoms include difficulty swallowing. We are talking about the esophagus, right? And the problem with people that are having difficulty swallowing, especially with the high muscle tone in the low esophageal sphincter. So we are going to see difficulty swallowing, frequent vomiting, right? As we were explaining before, when we decided to analyze the framework for the dysphagia, for the diet for dysphagia, right? So now more symptoms are going to be a feeling of fullness in the chest, of course, weight loss, yes, because the intake is not complete. Malnutrition, yes, and pulmonary complication and infections caused by the aspiration of food particles, especially during sleep. And that's good to know, NCLEX alert, when we are having this low esophageal sphincter issue. NCLEX alert, we can have aspiration of food particles. Surgical treatment of Acalasia involves dilating or cutting esophageal myotomy, that's the name of the surgery, the lower esophageal sphincter muscles. The postoperative medical nutrition therapy starts with oral liquids and progresses to a regular diet with you a few days. Avoiding very hot or cold foods, citrus juices, and highly spiced foods may help prevent irritation. It is also helpful for clients to eat frequent small meals as tolerated. Eat slowly, take small bites, and thoroughly chew their foods. Okay, so let's get into gastroesophageal reflux disease. We keep going down. We spoke about the esophagus. Now we are talking about GERD, gastroesophageal reflux disease, and some of you are having this topic for your final project. So it occurs when contents from the stomach reflux back into the esophagus because of LES incompetence. Incompetence, yes. So that's good to know. I think we spoke about this, and I made a graphic in the whiteboard about GERD. Okay, and like the stomach mucus does not protect the esophageal tissues from the hydrochloric acid. Yes, so I explained to you that This amount of these gastric contents from the stomach are well tolerated by the stomach, but it's not well tolerated by the esophagus because of the lack of enough mucus and certain cells that are protecting the esophagus, right? Um, so we have the hydrochloric acid and pepsin secreted in the stomach. The constant regurgitation of acidic gastric contents into the lower part of the esophagus is the lower part, okay? Sometimes this GERD is so severe that the reflux goes all the way to the throat, okay? So the lower part of the esophagus result in erosive esophagitis. In perisophageal peristalsis, prolonged and spontaneous LES relaxation, use of certain medications like anticholinergics, selective serotonin reuptake inhibitor, antidepressant, hiatal hernias that I explained also in class, scleroderma, and obesity are common contributors to chronic GERD. So I want you to remember that obesity is one of the major contributors of GERD, and I also explained that in class. Abdominal distension, right, can cause GERD. So, symptoms include frequent and severe heartburn within an hour after eating. That's another thing I want you to remember. It's very important in terms of assessment, so you can immediately assess and correlate the symptoms with the condition. Dysphagia and excessive belching, those three, okay? The pain sometimes move into the neck or jaw or down the arms. Long-term complications include aspiration and pneumonia. There you go. I would say that any issue that is related to problems with the esophagus can lead to pneumonia, aspiration and pneumonia, right? Also stenosis, the narrowing or stricture of the esophagus, esophageal ulcer or perforation, adenocarcinoma, and Barrett's esophagus. So I hope when you are listening to these videos or watching the videos, if you can not only listen, but you can also visualize how the problem is presenting in the anatomy of the body, right? That would be very important. Okay, Barrett's esophagus. So here you have the esophagus, where the circle is the representation of the hydrochloric acid or pepsin going into the esophagus, okay? So you can see the lower esophageal sphincter when there is a problem there, sometimes when it's too loose, or some others in the case of the people that is having high tone muscle in this sphincter, the muscle is closed, so they are having vomiting. So now we have fluid in the stomach, and there is another sphincter called the pyloric sphincter, which is the joint between the stomach and the duodenum, okay? So this was a good graphic. So let's move. GERD symptoms and medication necessity decrease concurrently with weight loss in obese individuals, particularly with abdominal obesity. Thus, weight reduction strategies are an important aspect. As I told you before, abdominal distension, fat adipose tissues, right, can increase the risk for GERD. But if you will lose weight, right, GERD is going to be vanished. Individuals with GERD frequently use antacids and medications that reduce acid production. Example, histamine 2 receptors, prophylactically to reduce symptoms, proton pump inhibitors, all your medications that ends on azole, your esomeprazole, lansoprazole, omeprazole, right? Are the mainstay of pharmacologic treatment for GERD symptoms and are effective in most clients. Fundoapplication is a surgical procedure that resolves LES function and esophageal peristalsis. So fundo application, what happens is that they take the upper part of the stomach, right? The side of the stomach. They just pull this up above the diaphragm, and they wrap this esophagus like we are wrapping a burrito, right? So we take this part, go up the diaphragm, and we wrap from the back around, and then they suture. So they tie the lower esophageal sphincter. Okay, that's a surgery in cases of patients that they cannot control the disease with lifestyle changes. So medical nutrition therapy for GERD and gastroesophageal disease. We have to increase lower esophageal sphincter pressure. Some individuals find it helpful to avoid excessive high-fat meals, fried food, high-fat meals, because all these foods, what are they doing? They are increasing the secretion of the hydrochloric acid and in general the gastric content. So you don't want to have excessive high fat meals, fried food, right? So that's good to know. Peppermint and spearmint containing food products. Here you go, the recommendations for those that are going to be presenting GERD. So now another goal is to decrease reflux frequency and volume, okay? So one goal is to increase the lower esophageal sphincter pressure, and another one is to decrease the reflux from the stomach to the esophagus. So these are the recommendations. You avoid eating at least 3 to 4 hours before going to bed. Raise the head of the bed 6 to 9 inches. And eat small meals. Now, another goal is clear food from the esophagus. So you have to sit upright while eating. Do not recline at least 2 hours after eating. And then another goal, decrease esophageal irritation. So you need to avoid foods containing, for example, alcohol, smoking, coffee, strong tea, chocolate, carbonated beverages, tomato and citrus juices, and spicy foods. So tomato has the same level of acidity as the gastric content. And that's something we need to know. Okay, so now let's move to hiatal hernia. The lower end of the esophagus normally enters the chest cavity through an opening in the diaphragm called the hiatus. So a hiatal hernia occurs when a portion of the upper stomach also protrudes through this opening. More common in obese adults. Again, people with obesity, they are in risk for GERD. They are in risk for gastroesophageal reflux, right, disease. They are in risk for hiatal hernia, for whom weight reduction is essential to treatment. Healthcare providers advise clients with hiatal hernias to eat small amounts of food at a time, to avoid lying down after meal, and to sleep with the head of the bed elevated to prevent the reflux of acidic stomach contents. So basically they are sharing kind of the same advice, right? The presence of acid enzymes and food mixture can irritate the lower esophagus and the upper herniated area of the stomach. So the frequent use of antacids helps to control the symptoms of heartburn. So I want you to remember this in general. There is a misconception between the antacid, the proton pump inhibitors, the H2 histamine receptor medications. None of them stop the acid content. Please remember this. None of them stop the acid content. We need the acid content to metabolize food. We cannot stop the acid in the stomach, coming from the stomach. These medications controls decrease, okay, in certain ways the production of acid content, but none of them stops the acid content. Okay, so when you see in the exam, this medication stops or inhibits the acid content, that's not the good answer. because these medications only decrease or controls the acidity. Okay, so stomach and duodenum, peptic ulcer disease. Okay, let me see this graph here. I think they are talking about the hiatal hernia here. Yes, hiatal hernia. Look at this graphic. A, this is the normal, right? And in B, we are having the hiatal hernia on the left. And then this one, C, is more severe, right? Very severe hiatal hernia. So now let's go back to stomach and duodenum. Okay, as we saw before in this graphic, right? From the stomach to the duodenum, we have the pyloric sphincter. We are talking about another part of the body. Okay, so anatomy is crucial to understand this chapter. Peptic ulcer disease. The general term peptic ulcer refers to a eroded mucosal lesion in the central portion of the GI tract. Lesions can occur in the lower esophagus, the stomach, or the duodenum, right? Which is the first part of the small intestine. Remember DJI, duodenum, jejunum, and ileum. Okay, so we are talking about the duodenum. Ulcers are common in the duodenal bulb, and that's good to know. Most ulcers occur there in a duodenal bulb because the gastric contents emptying there are the most concentrated. Okay, so it's at the end of the stomach when the contents are being transferred to a duodenal that most ulcers occur because of the concentration of gastric contents, okay? A peptic ulcer is a crater-like lesion in the wall of the stomach or duodenum, resulting from the continuous erosion of the tissue through the mucosal layer down to the muscular layers. Okay. So the etiology here is the most important part of peptic ulcer. Pay attention. Helicobacter pylori is the major causative organism of peptic ulcer disease. The disease was thought to be the result before, years ago, the result of excess stress, acid, or spicy food. They thought that before, right? You get ulcers because of stress, acids, or spicy foods. Although these factors may still exacerbate the disease, we know now that infection with H. pylori causes the majority of duodenal and gastric ulcers. The long-term use of non-steroidal anti-inflammatory, your NSAIDs, your ibuprofen, your Motrin, your Advil, right, is responsible for most of the remaining cases. Please do not confuse Tylenol, acetaminophen as a NSAIDs. It's a very common mistake in student nurses, okay? Acetaminophen, which is Tylenol, is another type of medication. It's not an NSAID. Lesions generally result from an imbalance among the ulcerative factors and the protective factors of the gastric mucosa. Some of all of the following three factors are involved. So we have the amount of gastric acid and pepsin secretions, and that's for your personal, your homework. Pepsin, you need to analyze and do your research of the role that pepsin has in the stomach. Then the extent of Helicobacter pylori infection. So we have the amount of gastric and pepsin, the extent of Helicobacter pylori. We are called Helicobacter from now on H. pylori. And the degree of tissue resistance and mucosal integrity. So H. pylori, a common spiraling rod-shaped bacteria, and that's the most scary part because this bacteria has a spiral rod shape. That's why the treatment is so aggressive, okay? Because if this bacteria is not eradicated from the system, it can easily underline, bold, highlight easily convert into cancer. Okay, so rod-shaped bacteria that inhabit the GI area around the pyloric bulb. It is believed to transfer from person to person through the fecal oral, I don't have to explain that, or oral routes. So whenever you buy food from deliveries, or you don't wash the food properly, your vegetables, your fruits properly, or maybe you kiss somebody that is having H. pylori, you will get it. Look at these pictures. Look at the crater-like lesion. Okay, these are amazing pictures. But the H. pylori is here. Those black particles are the H. pylori. Okay, so we have to eradicate. And this is not the complete bacteria, because remember, it's a spiral, so they are inserted all the way into the tissue. Okay, so non-steroidal anti-inflammatory drugs are widely used medication. This drug class includes ibuprofen. We mentioned that. Also, we can include aspirin in this class. So we have to treat patients in the psychologic factors. Also, we need to check the gut microbiota. And for this, probably we're going to request an endoscopy. Okay, clinical symptoms. So we are having abdominal pain and a burning sensation. And we are going to have also the presence and confirmation of gastric ulcers if we do the endoscopy. Hemorrhage may be one of the first clinical symptoms for some individuals. Inadequate dietary intake, iron deficiency anemia, of course the patient is going to be bleeding, and unintentional weight loss indicate nutritional risk associated with peptic ulcers. Okay, so medical intervention is going to be eliminating the cause, the bacteria. We are going to focus on the promotion of the mucosa, and for this we have 4 basic goals. We're going to alleviate or minimize the symptoms, promote healing, and eliminate the cause, and prevent complication. The drug therapy is going to be 4 types of drugs. We're going to use antibiotic, of course, this is a bacteria, antacids, hydrochloric acid secretion controllers, is not inhibitors. You have the histamine H2 receptor antagonists, PPI, reduce hydrochloric acid production, and mucosal protectors, of course, because of the damage. So here is that's good to know. Tetracycline and mineral absorption. These are antibiotics, the tetracycline. So minerals with a 2 charge, including magnesium, calcium, and iron, bond with tetracycline to form a non-viable compound. Thus, the body eliminates both the medication and the nutrient via feces. Now, any amount of calcium in particular significantly reduces the availability of tetracycline absorption. Thus, tetracycline is less effective and mineral absorption is poor. In other words, when you take your tetracycline, okay, and you want to absorb the antibiotic, okay, and the essential minerals, please avoid high calcium foods. For example, milk when you're taking your tetracyclines, right? Or iron dietary supplements, or antacids or laxatives that contain magnesium for at least 1 to 2 hours before or 2 to 3 hours after taking tetracyclines. So here you have lifestyle factors that you need to consider, like for example, You have to be mentally you need to have balance mentally, avoid stressful situations. You have to have adequate rest, relaxation, and sleep. But here you have a very interesting table between the risk factors for recurring peptic ulcers, patients in high risk. You can go through this, and patients in the moderate risk. Okay. So basically, for medical nutrition therapy and peptic ulcer disease, we need to start with a bland diet, has long since proved to be ineffective and lacking inadequate nutrition support for the healing process. Pay attention to this, it's very interesting. Such a restrictive diet is unnecessary nowadays because more effective medication regimens are available to control aid secretions and to assist with healing. So the main goal, the most important, is the general nutritional guidelines for patients with PUD, with peptic ulcer disease. Okay, is eating a well-balanced and healthy diet. Okay, and to improve antioxidant intake, maintain a healthy gut microbiota, increase tissue healing and maintenance, and to restore any nutrient deficiencies. A hearty intake of dietary antioxidants and phytonutrients provided by whole fruits and vegetables, that's very important, coupled with avoidance of food and behaviors known to increase oxidative stress, for example, eating trans fats, smoking, high alcohol intakes. Those are creating oxidative stress. Helps to restore GI well-being, microbiota diversity, and reduce the inflammatory response. In general, a healthy diet, healthy lifestyle, right? Avoiding acid stimulation, so we need to be careful with the food quantity, the irritants, like example, hot chili peppers, black pepper. Especially we need to avoid coffee. Coffee is very irritant in peptic ulcer disease. Chocolate, tea, right? We need to avoid the smoking, and the recommendations are to complete smoking cessation. Um, that's very important to recommend to patients. Um, Smoking also affects gastric acid secretion, induces oxidative stress, and hinders the effectiveness of drug therapy. So we're going to make a stop here. When we come back, we are going to check the lower gastrointestinal tract. Thank you for your attention.